How you doing, George?
I'm doing very well, Dan. Thank you.
Good. Okay. Well, I thought we would jump straight in and just ask sort of about what your profession is and what life has been like for you over the last few weeks that we've been in this situation.
So I'm a doctor, a junior doctor at the moment. I'm training to be a GP, and I'm a couple of years into that out of three. So I'm sort of a year and a half away from being a GP. So my life's been pretty centered around the coronavirus for the last few weeks. At the moment, I'm working in the hospital. I was working in the medical admissions unit, which is sort of where all the patients who are going to come in under just a general medical problem from A&E or from the community come in through the medical admissions unit.
So, had you been
Um,
working in that unit before this happened, or were you put there?
yeah,
Okay.
yeah. So I was working there for a couple of months, and I was supposed to be there for 6 months, but we've moved now to a super rota where people from all sorts of different areas in the hospital are all on the same rota, and we're split into teams, and we just rotate around different departments. um, which is quite a big change. We've never done anything like that before.
Is that happening in all hospitals, or is that just yours?
I think generally it is happening across the board. Yeah, um, everyone's moving to sort of an emergency type rota. Um, we've actually in because I work in the southwest, and we've got quite a low, relatively low level of coronavirus compared to other areas of the country.
Okay.
Um, so there hasn't been the same sort of work pressures that some people have had in sort of London and things like that.
Okay.
It's been fairly okay. And then the last couple of weeks, my partner had the coronavirus.
And
Um,
you're living together.
yeah, so she was off work for a week, and I'm have to be off work for 2 weeks. Um, so I'm in day 11 or 14, being in the house, not allowed out.
Right.
So I'm going a bit stir crazy in some ways, but
Yeah.
it's been okay.
And how are you feeling in terms of well, just within yourself, like what symptoms? Well, actually, let's start with. So, what was your sort of journey with it? Like having symptoms. What did you experience yourself?
So on this mega rota, me and my partner were both off for over the weekend. So we finished work on Friday, and then we were in the house Saturday, and then on Sunday, she started feeling just fairly hungover. We had a couple of glasses of wine the night before, but probably out of kilter with that throughout the day. And she was sort of playing off like it's nothing, and I thought maybe it's the start of the virus. And then overnight, she had a really high temperature. So about 3 in the morning, I woke up because she was so hot, basically, and moved to the spare room. And then the next day, she developed a cough. We actually tried to do a sort of a self quarantine, like a quarantine in the flat type situation. So for sort of 3 or 4 days, she stayed in the bedroom. We have an ensuite, and then I just brought her all of her meals, like a butler. Um, and but then the following day, I started to feel unwell, but I didn't have a fever or cough. I just had a real sense of sort of extreme lethargy and aching muscles and a headache. I felt a bit shivery, but not. It was kind of coming and going. It was very vague. So she went to the hospital. She drove to the hospital on the second day, I think, and got a swab, which was positive. And I had a swab, but probably a bit too early. It normally takes sort of a day three is a good day to get a swab, and I had it sort of more on. I only had the symptoms for about 24 hours, so my swab was negative, but
So
it can be.
does that make a difference then in terms of the
Yeah, it
days?
can do. Yeah, yeah. Well, there's an ideal kind of time frame to get the swab, which is sort of 3 days. after you develop the symptoms. You can have it 2 days after the symptoms, but yeah, my swab is negative, but we've seen a few kind of negative swabs, but with people who've got quite classic symptoms. So the test isn't perfect, basically.
How accurate is the test?
Um, I think it depends a lot on it's not necessarily the accuracy of the test. I think it depends a lot on how they're doing the test. Um, we've certainly seen some patients who've had classic sort of symptoms, and on the chest X-ray looked very convincing that it was coronavirus, but the test was negative.
Right.
So it's a bit difficult to know. I don't really know the exact figures of this of the how good the test is.
Yeah.
Essentially.
Okay. And did a lot of doctors did they struggle to, like, what was the process? Because obviously it happened so quickly. There's a lot of doctors and nurses like having to learn how to do, I guess, these tests and all this thing that's very coronavirus specific. Is there like training for that when you train to be a doctor? Is there like pandemic like training in terms of like the very basics, or did people have to learn quite quickly how to deal with this?
Well, so I think all kind of doctors have an awareness of pandemics and epidemiology and things like that from medical school, but we don't do any sort of practical training about it or anything like that.
Right.
They have a commands system in place, which goes up all the way up from like the level of management in the hospital up to the top commander in the Department of Health for dealing with emergencies. And that sort of structure just comes into play whenever there's some sort of emergency, whether that's a terrorist attack or a fire or a pandemic.
Yeah.
So we just use the same system as that. In terms of doing the actual practicality of treating these sort of patients, the swab is a nasopharyngeal swab, so that means a swab from the back of the nose. And that's kind of quite a standard sort of test that we do for other things. So there's not.
That means
there's
like
not really,
deep inside your nose, and you have to sort of go in from the nostril and just sort of go quite deep inside the nostril.
Yeah, I mean, I had it done. It was fairly uncomfortable for the couple of seconds that it took to do.
Yeah.
But it's bearable for sure.
Yeah.
So that sort of I don't think we needed any sort of extra training for that. In terms of treating the patients, we don't really have a specific treatment at the moment. So we're just doing what we always do, really, is treating oxygen levels and fluid levels and things like that, which we've been doing since we started. So there's not been much change in that respect.
Right. Okay. So is it sort of dealing with a lot of the work is just dealing with the symptoms, I guess, and trying to keep the effects of the virus down, as opposed to trying to treat the virus itself?
Yeah, that's exactly right. Yeah. So
right.
Some patients will come in and just need some oxygen for a few days. Other people need to have sort of help breathing with a non-invasive ventilation. So it's sort of like a mask or a hood that pushes air into your lungs, which is similar to sort of if you put your head out the window when you're driving in a car, and open your mouth. That pressure of air going into your chest is kind of it's a similar idea.
Yeah. Are you recommending that?
Yeah, if you're very unwell, go down the motorway.
You don't want to make like a Trump-style recommendation.
No, not. And then other patients need to be intubated. So our main tasks really are sorting out which patients are suitable for next level, like at the highest level of care, when they come into the hospital, and then treating the symptoms, keeping people as comfortable as we can, and then recognizing when somebody's deteriorating and needs to be moved to a higher level of care, essentially.
Right.
The main time.
So you were saying how like everyone has to do everything in a sense, like be a jack of all trades and sort of go between departments. Is that sort of what you were saying?
Yeah, so we've been mixed in. Our teams have been, but like the medical team has been bolstered with um, doctors from other areas. So my medical team has got an ophthalmology trainee, which is like a doctor who does eyes,
Right.
and we've got a surgeon, and they've just sort of been doing like because when you start as a doctor, your main tasks are administrative, really.
Oh, okay.
Writing in the notes and ordering tests and chasing them up and asking for for help.
So do you
Um,
sort of follow another doctor around, and you're doing the
yeah,
sort of administration for them type of thing at the start?
in a sense, you do the ward round in the morning.
Right.
So the senior doctor sees all the patients and makes the plans, and then your job is to carry out the plan essentially. And if there's any tests that come back as positive or needing action, then to contact them and ask what to do.
Okay.
So if you've got that sort of working knowledge of medicine, then you can always revert back to doing that sort of level of care.
Right. Right.
So they're still useful, even though they haven't worked on a medical ward for maybe some number of years.
Okay. And so you're still a junior doctor. So what does that mean in terms of is that the same for your role then? And it's quite administrative compared to when you're fully qualified, or what's the sort of difference between a junior doctor and once you've gone
Well,
past that stage?
yeah. So a junior doctor is a bit of a difficult term to understand. Essentially, anybody who's not a consultant or a GP is seen as a junior doctor.
Right.
Um, so there's various grades. So from your first year, you're a junior doctor, but then up to the year before you become a consultant, you're a junior doctor. So it's a bit, it doesn't really account for the sort of level of responsibility you have using that one term.
Right. So it sort of almost downplays the amount of responsibility you have by saying junior doctor.
Well, for some people, yeah, but for other people, yeah, for like the first year doctors,
Right.
their responsibility is less.
Right. Sure.
But I think I'm sort of at a level of I make some decisions, but other things I have to refer up the chain.
Hmm.
Just depends on the situation really. So
So
yeah.
So do you once you've completed the junior doctor phase, which is 2 years, isn't it?
So you do foundation training, which is 2 years. So your first year is provisionally licensed. So you don't have a full license to practice. There's a couple of things that you're sort of not allowed to do.
Right.
And then when you become in your second year of being a doctor, that's your full license.
Okay.
And then from there you enter your specialty training, or some people take years out, but if you wanted to be, say, a surgeon, then you start your core surgical training at that point, and starting in your third year, or core medical training, or if you want to be a GP like me, then you start your GP training.
Okay. So have you already started your GP training, or you will be doing that later on?
No, yeah. So your GP training's 3 years after after the first 2 years. So 5 years out of university is the minimum amount of time
Okay.
to be a GP. So
So
the first sort of 18 months you work in the hospital, and then you do 18 months in a GP practice.
okay.
General formula.
And is GP the only sort of thing you can go into which is more general? Do you have to either specialize or become a GP?
Yeah, one of the reasons I wanted to be a GP really is because I want to be a generalist,
Okay.
and it's really the only option for being a full generalist. You can be a general medical doctor,
Okay.
where so instead of specializing in one organ system, you work generally in the medical admissions unit, or we have some outpatient clinics where a general physician will see the patients, and they're quite generalists, but they wouldn't see any surgery or or anything to do with limbs or anything like that. So they wouldn't see pregnant people, kids usually. So it'd still only be generalized, but in the field of medicine.
Right. Okay. And so back to the coronavirus. So what has there been in terms of like the departments or specialization areas, where has there been a decrease in demand, or like it hasn't risen, and where has been a big increase in demand? I imagine sort of respiratory doctors are, sort of very important right now, and well, obviously all medical professions are important right now. But is there sort of, you mentioned eye doctors and things like that. Is there a shift between sort of how we're seeing with the economy? Like there's a shift between a lot more demand in some areas like supermarkets and online deliveries and things like that, and then there's a move away from a lot of other industries. Is that sort of happening in a hospital as well?
Yeah, so they've cancelled all elective stuff. So the hospital works in terms of in two groups of patients. There's the elective patients, which is elective is another word which means sort of planned. So if you're going to have a hip operation, then you would be an elective. Like if you're going to have a hip replacement because your hip's really sore, then you'd have an elective operation booked, and you'd come in on a planned day and have that operation. Whereas if you fell over and broke your hip, then you'd be an emergency candidate because your hip's now like in desperate need of being fixed.
Right, right.
So, yeah, so in preparation for this wave of patients that we thought we were going to get, they cancelled all of the elective operations. Especially with bigger operations, patients will generally go to intensive care after their operation, just for a couple of days, usually just to make sure that they're recovering well, well enough to go to the ward, or they might need a little bit of, blood pressure support, something like that. So to free up intensive care beds and essentially ventilators, they cancelled all of the elective operations. So the surgeons are just operating on an emergency list.
Right.
So everything that comes in as an emergency, they'll still do, because there's certain things that you can't not do, like appendixes, hip fractures, things like that.
Okay.
And then the ophthalmologists and the eye doctors and the ear, nose, and throat doctors, people like that, running a very much reduced service, again only for emergencies and trying to call the patients beforehand to sort of see if they can sort it out on the phone rather than them coming in.
So with these elective surgeries, so these are the ones that there's been an ongoing problem as opposed to a sudden emergency problem.
Yeah.
Are there any areas that are still going ahead? I imagine like cancers and things like that. That's still going ahead, isn't it? Or
Yes and no.
right, okay.
I think there's been a reduction, but I think that there's a bit of a risk benefit sort of analysis. So if you've got somebody who's going to have an operation that improves their 5-year survival by 3 or 4%, then the risk of them coming in getting the coronavirus possibly and is probably not worth the risk of the surgery. But in terms of things like bowel cancers, my understanding is that they were still going ahead, because if they didn't, then there's a risk that they would obstruct the bowel, and then they'd have to come in as an emergency and have the procedure anyway.
Right.
So, well, they might do. So they've been going ahead with those sort of things. Chemotherapy is another interesting area that's sort of a bit of a mismatch. They've definitely reduced they reduced the amount of chemotherapy that they're giving out. They rationalised it again from risk benefit.
Mm-hmm.
I think most patients wanted to carry on with it, anecdotally.
Mm-hmm. Sure.
But yeah, it's a really difficult question.
Okay. Yeah, that's fine. And yeah, it's not a case of feeling that anyone listening, it's not George isn't on to sort of give exact figures and to say exactly how things are. He's not someone who's going on the BBC and answering all the technical questions. It's just sort of his views and his experiences with it, really. So yeah, just to clarify that. Yeah. So what's been sort of on that note in terms of experiences? Like, is your partner, is she also working in the same field as you?
Um, yes, generally, yeah. So
Okay.
she's also training to be a GP.
Right. Okay.
Um, she's working in a similar area at the moment. We're both on this mega rota.
Okay. And you're sort of and you're both in the same hospital?
Yeah,
Okay. And you're both at the same stage in sort of your education or your progress in terms of uh,
yeah. We're both doing the same thing at the same time, basically. Yeah.
cool, cool. Is there competitiveness with it?
Not really. No, we don't. There's no competitiveness for jobs or anything like that. So,
Yeah.
yeah, there's not much of that.
What have you found, you know, uh, with you two when you talk or with your colleagues and things like that? What's the sort of feelings at the moment amongst the other NHS staff that you work with? What's the sort of mood that you're getting?
Well, with regards to the coronavirus,
Yeah, yeah, yeah. Since this sort of happened, and yeah, just yeah, in the last few weeks, I guess.
um, well, I think as I said before, the work pressure for us isn't so bad in this
Okay,
area, but whereas it is bad elsewhere.
okay.
At the hold. I think there's been a lot of anxiety about sort of personal health, you know, kind of worrying about bringing this infection home to your family,
Mm,
um, that kind of thing. And also there's just sort of a nervousness about, I think that one of the biggest problems that we've had is sort of dealing with uncertainty,
mm,
in terms of we're expecting this wave of patients, and the timeline was impossible to predict. So we just kind of planned for the worst case scenario, but we were kind of just waiting for it to happen, which was um, yeah, it was fairly difficult to deal with that level of uncertainty as to when
right.
it was going to happen. Whereas if it was, oh, it's going to be busy in a week, like for sure, and this is, what is expected of you, then you can sort of plan that out in your head.
Mm.
But yeah, it's more difficult when somebody says, we're not sure.
Do you think, in a sense, like the worst has been prepared for, but actually, it's not been as overwhelming just for your particular hospital than as might have been expected?
Yes, I mean we have had an influx of coronavirus patients,
Mm.
but it's very much within the realms of our capacity, and we've seen a massive drop off of other patients. Um, I don't know. Nobody really knows why. It's probably most likely that people are afraid to come to the hospital,
Mm.
um, and we've seen a few cases of people uh, putting off um, things that they should have come into hospital with, like heart attacks and strokes and things like that. So it's a really important kind of thing to get the message out that we're still open for business. And
Mm.
if you do have a serious medical problem, then you should still come to the hospital.
Yeah, yeah. So that
Uh,
seems to be something that I'm hearing as well. Again, it's just for me, it's just on the news and things like that. That a part of this drop is going to be people scared to go to the hospital still. Um, so what are the sort of avenues that people get if they're ill, on different levels, I guess, at the moment?
how do you mean?
So if you're ill, or yeah, what is the sort of difference in what they can do if someone gets ill? What avenues can they go down in terms of their GP and the hospital? What what are you
So,
sort of seeing?
so if you're unwell with coronavirus symptoms, Unless it's an emergency and you can't, you're really struggling to breathe, then you should call 999. But if you're stable but unwell, then the advice is to call 111. And they will arrange for you to be seen in a coronavirus assessment centre, essentially.
Okay.
We've opened one part of the hospital up as a respiratory assessment unit. And what the idea is that the coronavirus or suspected coronavirus patients will come in through that one entrance.
Right.
And it's all kind of kept in that area. And then we keep A&E free as a sort of a clean area.
Right.
But we've also had the A&E is also is still accepting the patients who are critically ill. So yeah, it depends on, but that will vary quite significantly depending on what your local kind of trust is set up. So
Sure.
the best thing to do is either 999 if it's an emergency, or 111 if you're worried but it's not a critical thing.
Yeah. And I guess, like you say, the main message is that if you're having severe problems, or any problems, but especially severe problems, an emergency, A&Es aren't shut down. They're not. It's not like you won't be able to get in the hospital.
No, absolutely not.
Yeah.
If anything, they're waiting around for some patients to come in.
Yeah.
But we're still operating. I mean, we're still doing treating patients for heart attacks, treating patients for strokes, like any serious medical problem. All the treatment's still available. There's no limitations in our area for that sort of thing. So
Okay.
Definitely worth coming to the hospital.
Yeah. Okay. On a slightly different note, it's up to you if you want to sort of go into this area or not. But do you have any thoughts on sort of how the government's been dealing with this, and what's been going on since the outbreak happened and since it's been locked down?
What's the government doing about it? I don't really have much to say about that, really.
Okay.
Yeah.
Okay.
I think we'll leave that if that's okay.
Yeah, that's fine. No problem. What do you feel like the future you're hoping or you're seeing that the future might be in terms of the NHS and the medical profession after this? Have you had any thoughts about that sort of thing, like what the future might hold or what you hope it will hold?
So we've seen quite a change in practice for GPs over this area. So we've been trying to move towards sort of video consultations for some time. A lot of GP practices have moved towards a telephone triage where they call the patients. All the patients who are going to come into the surgery that day get a phone call in the morning. And if it's something like, I need my prescription renewed, then we can do that over the phone and not waste an appointment time. And then we'll just see the patients who need examining, basically.
Okay.
So we've moved, because of the risk of coronavirus to healthcare professionals, we've moved quite significantly towards doing video kind of conferencing to see patients, video consultations. And it's worked out very well. And I think that that's something that everybody is sort of banking on being a persistent change.
Right.
Not going back towards doing as many face-to-face consultations. I think that there was a private company that was operating by doing sort of video consultations for GPs, which people would pay a fee and then they could see a GP on a video call. But I think that the way that they were going about things was criticised by a lot of people. They were sort of just giving out whatever the patient wanted, which wasn't necessarily in their best interests.
Right, sure.
And there's a bit of a danger with that sort of business model of, if somebody pays £50 for a consultation and says, I want some sleeping pills, then there's a pressure for the physician to offer them.
Yeah.
Whereas if you come to your GP and you've known them for years, and you can have a chat with them and see what the best thing is for them.
And
but Yeah, sorry.
So no, carry on, mate.
I was just saying, so there's they started using this new app, which apparently is very good, and it links with the patient's records, and the GPs are seeing their own patients through this video app, and it's working out very well, is what I've been told.
That's brilliant.
Yeah, so hopefully that's a positive change.
Yeah, and that seems to have. I mean, obviously, I haven't seen on the ground how quickly it's happened, but it seems to have happened very quickly. Like that they've actually, and the fact that you're saying it's working quite well.
Yeah.
What you've been told anyway, it's that's quite amazing that it's happened so quickly, and
It
this
is, yeah.
vital thing is
Another really big kind of change is there's a lot of patients in the hospital who are there for social reasons. So they've completed their treatment, but they aren't well enough to go back and live in their home.
right.
So they need a placement in like a care home or an interim facility.
So this sort of
Um,
typically be like older patients and things like that.
yeah, exactly. Yeah, it's
Right.
almost all well old things. Yeah, and they need a placement, but that takes a few days to sort out. They have to have these assessments to see what place is the most suitable for them, and then you have to contact their family, and they work out how they're going to pay for it. Uh, it all takes a few days. Um, but while that is happening, the patient's in hospital, and we don't need them to be there. If that makes
Mm,
sense. And we've lost a lot of community beds in the last sort of couple of decades,
right.
which has made that problem worse. But what's happened in this sort of crisis period is that these patients have gone to have been going to sort of like a care home and having the assessments there. So they're out of the hospital as soon as they're well, which has been excellent.
Wow.
And if we can keep that going, that would be a huge difference.
Yeah, that's amazing. I had no idea that was happening.
But the the difference is that the care home is taking a bit more risk on because they're taking these patients possibly without the correct equipment.
Sure.
So they're taking on a bit of risk, which they're happy to do at the moment. But whether they'll carry on after this is over is difficult to know. We'll
Sure.
have to see.
Sure. But I guess it's a good first step, and it's hopefully if there's motivation and the will to carry on this sort of streamlining of patients to make sure they stay in a stable condition and they're cared for, whether they're in the hospital or they're going into a care home and then back to their own home. Just working towards that goal, it can sort of be made more effective and more safe if the will's there to keep it going on, I guess.
Yeah, I mean, I have heard people say that we've made steps in the last few weeks that have been years in the making,
Right.
just out of necessity. So
Mm,
I think that there has been some positive changes in the healthcare structures, but whether that will persist is sort of up in the air. We don't know.
sure, sure. And like from my point of view, I'm not imposing my point of view on yours or anything, but
Sure, yeah.
the more streamlined, the more effective the NHS is with the resources, the better it is for everyone. I think there's this idea of like, we have to let the patient have whatever they want and as much money is pumped in as possible. But actually, these simple ideas like video calls when it's not needed to see them, or I mean, for me, for example, so I had an adrenal tumor a few years ago. I'm not going to say the actual term of it because it's too complicated to say. And but
Pheochromocytoma.
yeah, yeah, pheochromocytoma. But yeah, so I had that removed a few years ago, and a few weeks ago I had an appointment for genetic testing. So yeah, so it's just basically a consultation. It was just a consultation, but the appointment was at Hammersmith. And even before this sort of coronavirus got bad, it was still sort of, we had like one or two people maybe in the country who had it at this point, but it wasn't anywhere. No one really seemed to know as bad as it was going to be now. But anyway, so I asked them, just because I had to go all the way to Hammersmith and I live outside of London, I was wondering if I could just get a phone appointment. and they're like, yeah, that's fine. It's just a consultation. And I feel like what you were saying, off the back of that, having more consultations and thing that can be just as easily done over the phone, then that's just great for everyone. It saves on travel costs. It saves having that contact, with a doctor when it's not necessary, and that seems like possibly a good thing if we can do that more.
Yeah, I think it really would be great.
Mm,
Yeah, I think as well, a lot of the resistance of this has been that older people don't know how to use technology, this sort of idea, but actually they're fairly good. And most of them have somebody who can help them if they struggle. And seeing patients in a care home, there's always a carer there who can sort out a video link. So I think the barriers are less than we kind of think that they are.
Yeah, and it's a case of, even if there are older people who do struggle with that, then they can still go to their GP. It doesn't have to be a blanket thing for everyone. It's the minority, I think, now in this country that people don't know how to use technology and sort of video calls. I know, for example, one of my grandmothers, she's so computer illiterate. It's just crazy, but she knows how to use a phone, so she could still have phone consultations if she didn't need to see someone in person. And yeah, we can always help her out with video calls and things like that once we can see her again. So yeah, like you say, there are ways to do it.
Yeah, I think it would be good.
Cool. Well, yeah, that's really good news. I didn't know about, even more so, actually, better news, what you were saying about, these people going straight out of hospital, freeing up that bed, but then going into, a place of care is amazing.
Yeah.
Yeah.
Another thing we could talk about is have you heard much about do not resuscitate orders?
Is it to do with if they've said they don't want to be resuscitated? Like if someone has like a piece of paper in their wallet that says do not resuscitate or something like that, or?
Yeah, so it's generally a form,
right,
that a doctor will kind of fill out on behalf of the patient.
right.
And there's no kind of box for the patient to sign or anything like that, which is kind of quite a common misconception. And it's something that is really misunderstood by the public.
Right. Okay.
And it's sort of come to light on the eve of this crisis.
Okay.
So essentially, for what we're talking about is CPR, like what you learn in a first aid course if somebody's not breathing or doesn't have a heart rate. Doing chest compressions and kind of rescue breaths, but from like a bystander. Or in the hospital, we have other things that we do, such as sort of giving electric shocks with a defibrillator, using a like more invasive sort of ventilation, and putting intubating a patient, and giving them drugs like adrenaline, which there's some evidence that might help restart the heart.
Okay.
So the idea of it is basically if somebody's collapsed and their heart has stopped, you're pressing on their chest to squeeze their heart basically, and to keep the blood flowing to the brain, and to keep the brain alive, until you can identify what the cause of their cardiac arrest or the heart stopping is. So some of them causes might be a blood clot in the lungs, it might be a heart attack. Sometimes you can get air that's trapped between the lung and the chest wall that needs to be deflated. But what we're looking for essentially is a reversible cause, something that we can treat whilst we're doing CPR.
Right.
It's not a very good treatment, and the success rate varies quite significantly from age. So for a top level kind of like CPR in a young person, the rate of survival is still sort of 30-40%. For somebody in an advanced age, say like 80 or sort of in their 70s with lots of different health problems, If they were to come in with a pneumonia or something like that, and they were to get worse and worse to the point where their heart were to stop or they were to stop breathing, then doing chest compressions and giving them electric shocks is futile. Essentially,
Right.
it's not going to work. And of those that do survive, which is a minimal number, the vast majority end up in a sort of vegetative state for a few months,
Right.
and pass away anyway.
So what you're saying is that CPR, even when done in the hospital, for some patients, it can be more harm, and sometimes, or at very least, it doesn't do much. It can be that anyway. Obviously, CPR is very important, but for
people who are otherwise young and fit and healthy, or even sort of in the middle age category, it's worth doing. But for some patients, you can identify that CPR isn't in their best interests.
Right, sure.
And like CPR is a medical treatment in the same way that sort of surgery or chemotherapy is a medical treatment. And doctors can refuse to give out medical treatments that aren't in a patient's best interests.
Right, okay.
So it's a medical decision whether or not we think that a patient should be resuscitated. But we have quite a we think it's very important to sort of discuss it with the patient and not just make the decision on their behalf, which is without telling them. But when we're talking about that as a concept, we're talking about if their heart was to stop. Right. Whereas a lot of people kind of feel like that if they've got a do not resuscitate order, that means that they're not for any treatment, which isn't the case at all.
Right.
It's just that one specific treatment that's not.
So, for example, like if someone was diabetic and they needed an insulin injection and they came to the hospital and they were unconscious, you're not talking about a doctor in this scenario wouldn't be giving an insulin injection. It's more focused on restarting the heart.
Yeah, exactly. Yeah, right. If they were breathing and they had a heart rate, then every other treatment, would be offered to them.
Yeah.
It's just this one thing, and a lot of people can get themselves in a bit of get very worried about this, thinking that they want everything done for their relative. I don't want to let my nan die. But the problem is that if their nan's heart was to stop in this sort of situation, then they're going to die anyway.
Right.
But there's a kind of more of a concept of having a good death. Do you want to be surrounded by your friends and family as you slip away, or do you want sort of 10 people to come in the room and start doing electric shocks and invasive procedures which aren't necessary?
Are there some occasions where CPR doesn't happen and the patient can get better, or is it sort of like when it gets to the stage where CPR is needed to restart the heart that they're without intervention that they're not going to survive anyway?
So it is. They wouldn't survive. They would be extremely unlikely for someone's heart to stop and then to restart on its own and then to make a full recovery. It's not anything that I've never heard of a case like that. But.
Okay, cool. So let's break this down then. So what you're talking about is let's say someone who is 90, they come in, their heart stops for whatever reason, and the normal sort of public idea is that CPR needs to happen to save their life. But what you're saying is, in the vast majority of cases, CPR would have no impact to resuscitate this person and to make them better, and it could actually severely damage them. So if they do come around from it, then they could be in sort of vegetative state, and I guess not their brain would just not be working properly.
Yeah, they'd have a brain injury from the lack of oxygen over a prolonged period of time.
Right.
So yeah, again, this isn't a decision for people to make. If somebody sees someone collapse on the street, then to do their normal first aid is, that's important. But it's more of a discussion that doctors should be having with more patients, basically, to
Right.
explain, when they are at a certain age, what they'd like to happen to them. If they're, if they're in this situation.
And I
And
guess part of the problem and sort of thing maybe you might be alluding to, correct me if I'm wrong, is that a lot of stigma can come for doctors, because doctors have to make life and death decisions every day for their patients, and they're trying to do their best for the patients. Like these things can come along where family members of the patient and things like that, they blame the doctor and they think the doctor did it all wrong and they weren't trying to save their life. And what you're trying to say is basically more understanding of why doctors make these sort of choices hopefully will reduce some of the stigma and some of the judgment.
yeah, we're trying to get people to understand why why these decisions are being made, and to understand what the implications of them are. That it's not that we won't offer any treatment. It's just this one specific treatment for a certain group of frail and often elderly patients is not in their best interests. And try and have that discussion about it in advance, rather than when it comes to at 2 a.m. where somebody's deteriorating and we need to call their family and talk about it on the phone, is completely inappropriate. We should have talked to them about it when they first come into hospital, or the GP in the community, or whenever there's a good opportunity to.
So in your opinion, again, it's just your opinion, like I know you're not laying down any policies or anything like that,
Sure.
what do you think would be a good way to approach this? What do you think would be a good way for the public to understand this more in terms of like in the moment and just in general?
Well, I think we're kind of overdue a public discussion about it. Whether that's through a public information campaign, I think that would be very useful. But I think on an individual level, I think that doctors have to take some responsibility to talk to patients about this.
Right.
One of the real issues is as well is in general practice, where you're looking after a patient over quite a number of years. Is that this sort of discussion in a certain patient can sometimes ruin that patient-doctor relationship if you push them too hard. If they're adamant that they want to be resuscitated, and then there's a bit of a conflict there between the doctor and the patient, and it's difficult to know whether saying doing that against putting that order in against their wishes is more damaging than damaging that doctor-patient relationship and them not wanting to come to you for advice in the future, if that makes sense.
So what's the law around that? Is it that the patient has the final say?
No, so the patient does. So the law is that the doctor makes the treatment decision.
Oh, okay.
So there's no expectation from the family or the patient that they have to sign up to anything or make any decision.
But if the patient has said beforehand that in all scenarios I want to be resuscitated, is that then?
The patients can't demand treatment, but they can refuse it.
Right.
So the doctor decides what is on the menu, and the patients can choose from those items.
Yeah. Okay. Nice metaphor to explain it. Okay. So all right. So that's cleared up something, because I was thinking of sort of about the thing about blood transfusion. There's some patients that refuse blood transfusions, aren't there?
Yeah.
So that's allowed because they're refusing treatment.
Yes, absolutely. And
right.
If they really want to, so where the difficulty comes is if somebody's refuses, say I don't want a blood transfusion, and then they come in unconscious, and you can't ask them whether or not you treat them in their best interest.
Yeah.
Because if they die without the treatment, So what patients who kind of refuse blood transfusions are encouraged to do is fill out an advance directive, which is a legal document that says in all scenarios I refuse to have any other, I
Yeah,
refuse to have
I
treatment.
remember filling out one of them.
Oh right.
Yeah.
Yeah.
Sorry, carry on. I was just interjecting.
No, that's fine.
Sorry, carry on. Were you still
No,
going on?
I think I finished what I was going to say. Yeah,
Oh,
so
okay.
just advanced directives. Yeah, and advanced directives can also cover things like patients who say, "Oh, I don't want to come back to hospital. I just want to have whatever treatment is available in my home. I don't want to come into hospital, have needles jammed into me and stuff like that."
Okay.
And we're trying to think more and more about this sort of thing. That if we have a very very extremely frail elderly patient with severe dementia, are we really doing the right thing for them to bring them into hospital? Kind of put a needle in their arm and give them antibiotics while they're in extreme distress and things like that.
It's a really interesting point, actually, even now. But the reason it's sort of quite relevant now is because a lot of families are now not able to be by their loved one's bedside, for good reason, in the sense of trying to stop the spread of infection. But the way it ties into what you're saying is that having, like you say, a good death, like being by, instead of, like you say, a load of health professionals trying to revive it in quite a very intrusive way, and with needles in the arms and pushing down their chest and things like that. What is it not something that we should be, or yeah, that a lot of families would want to be there in a more calm situation, just be the ones next to their loved one while they slip away a lot more peacefully. And that's
yeah. Sorry, what was you saying?
That's, I guess, what doctors who make these sort of decisions, that's what they're saying, is it's like, we're doing this for that reason. There is such a thing as a good death, and some scenarios, a good death happens by not trying to resuscitate.
Exactly. Yeah. Yeah. I think that's exactly right.
But
and yeah, and I think that again, the point of trying to talk about these things in advance, and I think that if anybody has an elderly relative, and even if they're in a good state of health, talking to them about what they'd want to happen, in the next 5 years, the next 10 years,
right,
at the end of their life, whether they'd like to. Some people are very keen to die at home. Some
so
people, yeah.
So let's get specific then. What sort of bracket do you think people can be starting to have these conversations? What people fall into the bracket of might not be resuscitated, and they should start to have these conversations about, like, above what age range roughly, or people with certain health problems anyway? Is there anything you can say in terms of, if someone knows someone within this bracket, then it would be a good idea for them to start to have this conversation about resuscitation?
So I think that we've got a concept that sort of combines age and health into one bracket, which is frailty.
Okay.
So frailty is essentially what a person can do for themselves. So we've got a scale of from 1 to 9, and essentially 9 is somebody who's on death's door, and 1 is somebody who's very fit and very active, sort of like somebody who goes running and things like that. And what we're looking for is people who are sort of slowed down. Maybe they go out of the house, sort of just walk up to the end of the road to the shop, but can't really get around much more than that. That sort of, maybe they need help with their shopping, or so when somebody started to approach that boundary of needing assistance, I think is quite a good time. But there's no, as I said, there's no kind of there's no formula for knowing who needs to make these sort of plans.
Yeah.
It's just
but as a general rule, if you feel that someone is in a quote frail situation, health wise or in terms of age or both together, then it's probably a good idea just to have this conversation at some point.
Yeah, I think anybody who's sort of elderly, just talking with them, or has a life-limiting condition, that kind of thing, where you just, I think, it's just important to establish the facts, but it's a good conversation to have with a GP, I think, as well as with the family, and then to get that as a, documented, so that when the situation arises, there's some information available to know what the person would have wanted if they aren't able to make their own decisions at the time.
That's a great idea about GP as well. That's a great suggestion, sort of having the conversation with the person, your family and things like that, but also going with the person to a GP and having this conversation with their GP would also add that another level of just input into the conversation, and maybe answer a few questions. I think that's an amazing point to bring up. Is there anything else along those lines that you sort of wanted to talk about with that?
Not really. No, I think that we've covered most of it, haven't we? Unless you've got any more kind of questions about it. But I think, it's just important to think that as a doctor, you're always trying to do the best for the patient, and that we wouldn't be doing anything like this if it was, there's no government mandated sort of policy from above saying you have to do this or anything like that, which it seems to be, social media seems to be awash with these sort of rumours that the NHS is killing off the elderly and stuff like that, which is not the case at all.
Yeah. And isn't there an oath you take as well when you join the NHS?
No, that's quite a common misconception. We don't do the Hippocratic Oath. Yeah, we don't do that.
Oh, fair enough.
But we have to abide by certain sort of guidelines, that like the GMC produce guidelines for ethical working, things like that, which we follow. But there's no Hippocratic Oath. Oh, okay,
fair enough. Yeah, exactly. Yeah, I would second that from someone who's not in the NHS and not working in the NHS. But you guys, you go through training for such a long time, and there are ethical policies in place, as there are with any organisation. And you're just trying to do your best. And I think, I'm really glad you brought this up, the sort of do not resuscitate sort of policy, and because I hadn't thought about it. It wasn't something I was thinking to bring up today, but I think the point of this podcast, part of the point of this podcast is for people, the guests on it, to be able to say what they want to say and to get a message out there that they want to get, and especially something as important as that. So thank you for bringing that up. I think it's a really, really important point.
Yeah, well, thank you very much.
Cool. Well, that actually leads us to the end now, because we've done about an hour.
Oh, excellent. Okay.
Yeah.
Great. Well, thanks very much, Dan.
No, thank you. And I'll just, before we go, I'll just say to anyone listening, please feel free to continue this conversation by commenting with any thoughts you have, or please contact me to come on the show yourself. I'd like to get as many different guests as we can. And in terms of what we've talked about today, just to summarise and for you to all think about, we've talked about the response from hospitals in terms of the coronavirus. We've talked about the stages of being a junior doctor, and sort of what that involves. And we talked about, the second half of the conversation was brought up by George Woodger. I call him Woodger in personal life, but brought up by George. We talked about the whole concept of do not resuscitate, which was brilliant as well. So listeners, please feel free to comment and have a think about that. But most of all, just thank you very much, George.
Thanks very much, Dan. All right, see you later.
See you later. Bye-bye. There's something else I'd like to say to any listeners, all three of you. This podcast is an ongoing process. It's an ongoing experiment. I'm trying things out and seeing what works and what doesn't. And so any feedback on this or other episodes will be really appreciated. I don't want this podcast to just be for my own enjoyment. The goal is for it to benefit people in some way. And constructive feedback is the best way to know if this goal is being achieved. If I don't know something's rubbish, then I'll just keep producing rubbish. If I don't know something's good, then I'll just stop producing anything good. And also, if you think of anyone that you know that would be a good guest for me to chat to, then please let me know. I would love the opportunity to speak to a wide range of people about an even wider range of subjects. Thank you for taking the time to listen, and I hope you continue the conversation. Bye for now.